Today we are going to talk about the anesthesia for cesarean section. The key points of this discussion would be: we do anesthesia for two persons and not one, the mother and the baby, so we should take extra caution doing this procedure. The physiological changes during pregnancy we should consider, and complication that might happen during such procedure. We should prepare for such a problem. Special consideration, as we can always face such problems in anesthesia as difficult intubation and complication, hemorrhage, decreased blood pressure, and so on. Now, talking about the anesthesia in cesarean section, we should understand some facts about cesarean section itself. These facts would help us to estimate and give the proper amount of fluid and blood if needed. This operation is usually have a moderate blood loss, so a large IV cannula should be secured. Another large IV access should be ready if hemorrhage occurs. Usually we give 1 to 3 liters for replacement of normal saline or ringer. We may also infuse 1 to 2 liters of crystalloid plus or minus some colloid, half a liter, in the immediate prior to the regional anesthesia if regional anesthesia was chosen for the procedure. The typical blood loss in cesarean section ranges between 700 to 1 liter of blood. So we should be prepared for a rapid infusion, and blood warmer and blood transfusion was required. Monitoring and positioning of the patient. Of course, the standard monitor should be applied at all times during the anesthesia. Also, fetal heart rate monitor should be available, plus or minus CVP, arterial line, and arterial blood monitor should be the non-invasive type. CVP may be used occasionally. What about the position? The position should be left uterine displacement. A blanket under the right hip, or the table should be tilted. Why we should do that? To minimize the aortocaval compression. Type of anesthesia used. Either we use local anesthesia, either infiltration or tab block, but this is very rare. I myself have just used the infiltration of anesthesia once. Tab block is used mainly for the post-operative analgesia nowadays. Regional anesthesia, either spinal or epidural or combined spinal epidural or general anesthesia. Advantage of regional anesthesia: avoid aspiration, because these patients are very liable to aspirate during general anesthesia. Avoid neonatal depression by the general anesthesia and the drug given, and it has much blood loss, and post-operative analgesia is much better. Now, we start with spinal anesthesia. The key points that we should always think of is the occurrence of hypotension, post-operative headache, the difficulty in controlling the level of anesthesia, because pregnant woman needs less volume of anesthesia, and the dosage that is required. Apply a monitor and administer fluid and position the patient as we saw in the picture. Metoclopramide prior to the block decrease the incidence of the nausea and vomiting, and we should use a 25 to 27 gauge pencil point needle. The pencil point needle is a better choice because it decreases the post-spinal headache. If the technical difficulties are present or urgent situation, we use a larger pencil point needle to make the procedure easier. Inject hyperbaric 0.75% spinal bupivacaine, 11 or 12 milligram, that's about 1.5 to 1.6 milli, or plus or minus fentanyl, 10 to 20 microgram. Of course, a preservative-free morphine, if present, 0.1 to 0.2 milligram, and position the patient with left uterine displacement. Monitoring and treat blood pressure reduction if happened. Adjust the operative table position to ensure T4 level of anesthesia. That is by lowering the head of the patient a little bit so that the local anesthetic injection can spread further. If anesthesia is inadequate and time permits, consider repeated block with combined spinal epidural anesthesia or spinal anesthesia or an epidural catheter. Of course, when we do spinal anesthesia, we should be very careful to use the proper dose, as re-spinal is not that safe in pregnancy. But sometimes we have to weigh the benefit against of the spinal or re-spinaling the anesthesia against the problems that we might face during the general anesthesia. And treat the inadequate anesthesia with other options like giving a mild dose of ketamine or some sort of sedation. But this is not very recommended. If the condition persists, we should change the plan to general anesthesia. This is the pencil tipped compared to the normal spinal needle, and as I've said before, the pencil tip needle decreases the post-operative headache. Now, how can we reduce the incidence and the severity of the blood pressure reduction during our post-spinal anesthesia in pregnancy? Fluid loading by 1 to 1.5 liter of crystalloid or half a liter of colloid, preloading, leg wrapping and compression stockings, and vasopressor infusion. Phenylephrine is of choice, 25 to 40 microgram per minute. Now, what if spinal anesthesia led to sympathetic block and severe hypotension or bradycardia? What do we do in that condition? Bolus dose of vasopressor, especially phenylephrine, 50 to 100 microgram, or epinephrine 5 to 10 milligram should be given. Phenylephrine is much better because it has a rapid onset, the efficacy to treat the decrease in the systemic vascular resistance, and the limited placental transfer makes it the drug of choice. Ephedrine may be associated with increased fetal acidosis. Atropine 0.5 milligram IV should be used to treat bradycardia. Considering the use of epinephrine, 50 to 100 microgram IV if other vasopressor are unsuccessful. What about the epidural? The epidural has a more difficult technique and time consuming more than the spinal. It has a weaker effect on analgesia, and the drug used is bupivacaine. It has a longer time to work, and as we have said before, the level must be at least T4. injection of 15 to 20 ml 2%, 300 to 400 milligram of lidocaine with a 1 to 200,000 epinephrine could be given with an increment dose of 75 to 100 microgram. Sodium bicarbonate 1 milli equivalent per 10 milliliter lidocaine increase the onset and hasten it and improve the block quality but increase the risk of decreased blood pressure. Bupivacaine or levobupivacaine or ropivacaine 0.5%, 15 to 20 milliliter with or without epinephrine and or fentanyl should be given, and it should produce adequate surgical anesthesia within 5 to 10 minutes. Left uterine dysplasia is best achieved by putting a towel or a wedge under the right hip. Administer oxygen by mask or nasal cannula and continuous monitoring the fetal heart rate. Monitor blood pressure every minute, then every 3 to 5 minutes. Treat blood pressure as we have said before. Maintain blood pressure at basal level to optimize placental perfusion is very important. For inadequate anesthesia, we give additional epidural local anesthesia 50 to 100 microgram fentanyl IV, or give 50% nitrous oxide or what we call Intinox, ketamine, midazolam as sedative, or infiltrate with local anesthesia. Patient must remain conscious to avoid the risk of aspiration, and if all of these measures failed, we should convert the patient to general anesthesia. After the delivery, rapid infusion of oxytocin 10 to 20 units per hour, monitor for excessive blood loss, and that significant blood loss can occur quickly and outside of direct observation and is often underestimated. So we should really take a good care about the blood loss. Chest pain, mild desaturation may be due to irritation of the diaphragm by blood or packs, too high or inadequate level of anesthesia, or venous air or amniotic fluid embolism. So it's a variety of diagnoses that we should consider if such problems occur. But ST segment changes in ECG may occur, but it is not that significant in pregnancy. What about combined spinal epidural? An alternative technique is to use a combined spinal epidural anesthesia. It is combine the flexibility and continuous epidural anesthesia and the rapid onset and density of the spinal block. Apply and monitor, as we have said, giving the fluid the same way and position of the patient. Most common technique is in needle through the needle. How can we do that? When the epidural space is located with a standard Tohi needle, insert a 25 gauge pencil point needle through it and administer the dose required for spinal anesthesia using bupivacaine and narcotics as needed. Then put the epidural catheter and secure it and use it if we need more anesthesia. Now, what about the GA, general anesthesia? We should put in mind that we should give pre-medication with antacid and metoclopramide Left uterine displacement, as we have said before, pre-oxygenation is very important because the pregnant woman rapidly uses oxygen and rapidly desaturates. Rapid sequent cross induction with cricoid pressure to avoid the aspiration, which is very common during pregnancy, and we should use a lower concentration of volatile anesthetic. Why? Because volatile anesthetic tend to relax the uterus. Induction by, first we elevate the right hip, as we have said. Pre-oxygenation for 3 minutes or 3 to 5 minutes. But if we use 4 to 8 maximal inspiratory breaths in 30 seconds is satisfactory, especially if we are facing an emergency. Head up and CPAP may improve oxygenation in obese patient. Place patient in a maximal sniff position, ramp patient if necessary to optimize the position of intubation. After patient is prepared and wrapped and the obstetric team is ready to begin, perform rapid sequence induction with cricoid pressure. How can we do that? Administer propofol 2 to 3 milligram per kilogram or ketamine 1 to 1.5 milligram per kilogram or etomidate 0.2 to 0.6 milligram per kilogram, these in hypovolemic or cardiovascular unstable patients. Then succinylcholine 1 to 1.5 milligram per kilogram to induce general anesthesia and facilitate intubation. Inflate the cuff and verify tracheal placement by end-tidal carbon dioxide wave and Oscalt bilateral breath sounds. Nitrous oxide or Intunox with isoflurane, sevoflurane or risflurane may be used. We have to limit the MAC to prevent uterine atony. We can do propofol infusion to maintain and to abolish the uterine relaxant effect of the halogenated agent. But the propofol unfortunately may cause neonatal depression. Usually we have to avoid hypocapnia during controlled ventilation, which may decrease uterine blood flow. After delivery, we may add opioids, fentanyl for example, and adjust the volatile and nitrous oxide concentration if necessary. We may decrease the concentration of the volatile anesthetic and raise the concentration of nitrous oxide, or according to the situation. And remember, volatile anesthesia have the ability to relax the uterus, and we do not want that because a relaxed uterus cause hemorrhage and bleeding. Now, we should give oxytocin infusion and we should note the uterine contraction. If it is not contracted, we should stop the inhalational agent and give methergine. Administer small dose of muscle relaxant after the delivery of the baby, that if is needed. And at the end, we should reverse the muscle relaxant by newstigmine 0.05 milligram per kg and glycopyrrolate 0.01 milligram per kg. If this is not present, we may use atropine 0.02 milligram per kg. Well, at that point we should consider titrating longer acting opioids for postpartum analgesia. For example, hydromorphine. After the delivery of the baby, midazolam 1 to 2 milligram may be given to avoid maternal awareness, which is a common problem in the patient undergoing general anesthesia for cesarean section. We may also consider tab block for post-operative analgesia. We should delay the extubation until the patient is fully awake and muscle strength return to normal because of the fear of aspiration. What about the pain management after the delivery? If you are using epidural, we should give a morphine free in the epidural, about 2 to 4 milligram, or intrathecal morphine, also preservative free, 0.1 to 0.2 milligram, with the spinal anesthesia when we give that. Common side effects of the morphine is pruritus, nausea, and rarely respiratory depression. Nalbuphine and naloxone are used to reverse these side effects. Metoclopramide and or ondansetron may be given if needed. Parenteral opioids, example IV, fentanyl or hydromorphine, can be given in bolus or patient-controlled analgesia in the recovery room. Non-steroidal anti-inflammatory drugs can either be given IV or by patient-controlled analgesia. Also, acetaminophen IV 1000 milligram can be also given. If oral analgesia is possible, non-steroidal anti-inflammatory drugs can be given, say ibuprofen and acetaminophen. And of course, we talked about the tab block before. What about difficult intubation? Why is it a common problem to intubate a pregnant woman? Because a pregnant woman usually have airway edema, usually have large breast that interferes with the intubation process, rapid occurrence of hypoxia because the mother consumes oxygen rapidly together with the fetus and have hyperdynamic circulation, and the high risk of aspiration because there is delayed gastric emptying of the pregnant woman. There is the pressure of the fetus on the stomach that makes it easy to vomit and aspirate. Also, the hormones of pregnancy can lead to nausea and vomiting. Failed intubation. In case of failed intubation, oxygenation and face mask ventilation must become appropriate, and numerous attempts to intubate should be avoided. Careful help and quickly decide whether surgery must proceed. The risk of continuing with GA and cricoid pressure must be weighed against the risk of allowing the mother to awaken. If the mask ventilation is impossible, quickly attempt ventilation with laryngeal mask. If this succeeds, either continue to use throughout the case or place an endotracheal tube through the laryngeal mask with or without a flexible bronchoscope. Alternatively, use intubating laryngeal mask from the start. You can also use Procil laryngeal mask. It has been used successfully as a rescue supraglottic airway device in this situation, and may lessen the necessity of endotracheal intubation. Cricoid pressure may interfere with the mask ventilation or the laryngeal mask airway placement and should be released if necessary. If laryngeal mask fail to allow ventilation, attempt emergency transtracheal ventilation using a 12 or 14 gauge intravenous catheter and appropriate tubing to connect to a high pressure oxygen source, i.e. jet ventilator. If these measures are unsuccessful, an emergency cricothyrotomy or osteotomy. If these measures are unsuccessful, emergency cricothyrotomy should be performed by experienced personnel. Planning for failed intubation must occur before it actually happens. A difficult intubation tray include video laryngoscope, supraglottic airway, equipment for emergency jet ventilation must be equipped and nearby. This is the difficult intubation algorithm. It can shows the different steps of difficult obstetric intubation. Algorithm 1, safe obstetric general anesthesia. Algorithm 2, if obstetric failed tracheal intubation. Algorithm 3, cannot intubate, cannot oxygenate scenario. What is the complication that can happen? Postpartum hemorrhage or intrapartum hemorrhage. This can be due to many causes, example uterine atony, placenta accreta or retained placenta, uterine rupture or uterine artery trauma. This would not be discussed in details in this section, but maybe in other lectures. Pregnancy and C-section increase the risk of venous thromboembolism. How to diagnose? If pleuritic chest pain is present, cough, hypoxia, increase respiratory rate and heart rate. Treatment is supportive mainly with 100% oxygen, volume expansion, and vasopressors. What about aspiration? Aspiration is a risk in pregnant patient because the gastric pH is less than 2.5 and could be prevented by decreased gastric volume and decreased gastric acidity by antacids or H blockers. Awareness. This happens in 3 to 25% of the cases. It is caused because we use low dose anesthesia and the risks: sympathetic stimulation, decreased uteroplacental blood flow, and psychic trauma. How to prevent this? By giving sedatives and assuring the patient. Fetus and anesthesia. Maternal hyperventilation, hypocarbia, decreased uterine blood flow. Effect of anesthetic drug: decreased blood pressure and decreased uterine blood flow. Induction delivery interval should be limited to 10 to 20 minutes to avoid any fetal distress. Thank you.